The response assessment in myeloma, as you can imagine, is evolving. And as we have more techniques available, then we can work more and more on this and learn more on the disease and on the patient's outcome. But before, we have to have the basic and then the minimal residual. And in minimal residual disease, the flow cytometry was developed first in Salamanca, then in UK, and then is expanded even in the US, and I believe that this will be established. And also the molecular. The molecular is a little more complicated, but there is a good correlation between the flow cytometry minimal residual disease measurement and the molecular measurement, the next generation sequencing. And then also the imaging techniques by PET-CT, particularly PET, looking at the metabolic activity of the disease outside the bone marrow, can be very helpful also. So this will be all established. We started with flow cytometry, so-called 8 colors. Now we have first 4 colors, now we have 8 colors. And the minimal residual disease, to be valuable for the patient, has to be a deep response, very low quantity of remaining myeloma cells. So minimal residual disease with 4 colors is not better than conventional complete remission. So we have to go to detect a single cell among 10 million. So this is very valuable. And the patients who are minimal residual disease negative at high level, they enjoy a very long-term disease control. And a subgroup of these patients, particularly those who have received high-dose therapy, can be cured. And this is continued complete response beyond 10 years of discontinuing treatment. So it is very, very important, is associated with prognosis and can identify the subgroup of patients that can be cured. No, I believe that we are at this, and the minimal residual disease can be useful at any step of the disease. It is always good to reduce the disease as much as possible, and today is associated with a favorable outcome, even with cure for some patients. And then this can help to monitor the disease and also to guide the duration of the treatment. So in patients with minimal residual disease negative, long-lasting, we can stop treatment more safely.